The mechanism of action is actually not so easy because we have some complicating factor, and has already been demonstrated and nicely illustrated by Dr. Fraser this morning, that CLL cells not only inside the cell have these mechanisms that I just showed you, they strongly depend on the microenvironment, so on the niche they live in. And as I said, they can't live outside. They are addicted to this. So we need to understand this, and I will show you a couple of surprising data, if I'm just getting this to work. All right, so basically, as I said, it's addicted to the host, and what you will see in any tissue where CLL cells actually live, they are not alone. Here's one example, and I think the most important cell type that is allowing CLL cells to survive are macrophages. They are stained in red here, and you see the majority of cells are lymphocytes, but these macrophages serve like nurse-like cells for these, or like feeding cells. And a postdoc in our laboratory in Cologne has recently shown that the therapeutic role of many of the agents in CLL depend on the presence of macrophages very often. So you have to neutralize the mechanism. Basically, if you take lymph nodes or lymphoma in general, you need a couple of elements to make them grow. They need to have vessels, they need to have additional cells, including macrophages. And so lymphomagenesis and CLL needs a couple of factors to be manifest and to have a disease progression. And for therapy, for antibody therapies, basically, they don't work by themselves. They interact in this microenvironment, and how, I'm going to show you in a second. So a long series of experiments published recently in the distinguished journal Cell showed that very often in some compartments, antibodies, including rituximab or alemtuzumab, so the antibodies used for CLL, don't work alone. And there's some organs, we know that, for instance, alemtuzumab does not work so well in lymph nodes. Why is that the case? So what they were able to show is that the efficacy of the antibodies to work is depending on the existence of macrophages in the proximity of tumor cells. So if you don't have them, they don't work. So here, in untreated, this is a 3D picture of a tissue, bone marrow in this case, and you see that they don't contain too many of these macrophages because they are stained in red. Yeah, you can see there is only green cells in the untreated population and some yellow cells, but not the red cells. And the red color is staining for macrophages in this marrow. So if you add chemotherapy, all of a sudden, cyclophosphamide, you could use chlorambucil, something else, they get attracted to the bone marrow. And if you add antibody, then you have therapeutic efficacy. And that's shown on the right side. Strange thing. Now, since this is working so weakly, I propose to almost give you a sign to move ahead, because otherwise I think I'm kind of lost. I think the battery might be weaker than it used to be. Yeah, it's actually the case, because the pointer doesn't work anymore, so it doesn't seem to have a battery. So I give you a sign like this, and you can move ahead, okay? Until I get a fresh battery. All right, so now you should move ahead, please. One more time. And so you see that the therapeutic efficacy of this is basically dependent on the coexistence of a chemotherapy plus antibody, and a long series of experiments I don't have the time to show you, but now you have to click a few times. What you see here is you treat with cyclophosphamide, and then the CLL cells all of a sudden release cytokines after this. This is activating macrophages, and this population that is needed in the proximity all of a sudden is able to stimulate the immune response, and only the coexistence of this is able to then kill the cells when an antibody comes in, because the antibody has one end that binds to the leukemia cell and one end that binds to the innate immune cells like macrophages and NK cells. So these two mechanisms need to be combined. And so very often we need the microenvironment, the appropriate microenvironment, to kill CLL cells. That's what this shows. And we have actually overlooked this phenomenon strongly in the past. Now this cartoon you have seen already, and I will emphasize one more time how important these molecules have become. So to the left, you see the B-cell receptor, or its formation in CLL. That's the pre-BCR, B-cell receptor. Downstream of that, there is a lot of proteins. They are in complexes, and they are called the kinases that stimulate all the survival of the cell. So I showed it to you in a simplified version before. Now this is a bit more real, still very simplified. And you see kinases like LIN, which is a Src kinase, or BTK, which is a Bruton tyrosine kinase, a target for ibrutinib, or PI3 kinase, which is the target for idelalisib. And all these kinases work together in order to activate NF-kappa B downstream. So you see the arrows going down, and then this ultimately stimulates survival. The same signals are also fed by the microenvironment, and we've shown that many of the receptors, many different receptors, funnel into the same pathway. So they are very important, and they have led to the development of important treatments for CLL and for lymphoma. Now, what's surprising, though, is that when you stimulate cell lines, and I'm actually trying to show you something very surprising to us, the mechanism of action does not seem so clearly understood as we thought. So they're always sold and marketed as B-cell receptor signaling molecules, and I think this is not so clear. So you see they are positioned there, and we set out and studied one of those kinases, actually LIN or Src kinase, to see whether they are really essential for this, because LIN is activating BTK, and so we wondered whether we could actually show the mechanism more clearly. Next one. So this is work of Hien Nguyen, a very talented Vietnamese doctoral student. Now she got her postdoc, and she did animal experiments. There's an animal model for CLL that is allowing us to very nicely study this disease. Like in humans, it has an onset over time. And she asked whether these CLLs will develop in the absence of this kinase. We did the same experiments with BTK. They are not as mature yet. But can you actually have a CLL and not have the kinase? And actually, if you think about logically, there shouldn't be a CLL, because if you don't have the kinase to be activated by the B-cell receptor, they should not grow the cells. If it's an essential molecule, that was the question. Next one. So, as expected, somehow, if you take away this kinase, which is by genetic manipulation of the animals that in the beginning live a total normal life, if you take away the kinase, which is shown here by LIN negative, so they don't have this molecule, it's basically knocked out. The CLL, you see in red, grows a lot slower. This is original blood counts, like in patients, so you see in month by month they grow, but it's a lot slower. So the kinase is needed for this. Next one. And you look at the organs like liver and spleens, to check whether they are growing normally, and you can see, well, in normal animals, they don't grow, they keep their normal size. However, in CLL, we see an increase in organ weight, and here on the liver, the red animals, the red dots, you see that in the absence of LIN, the disease seems to be less prevalent. In the spleen, there's not a big difference. So, yes, LIN is needed for this disease, and that sounds logical somehow. So that was actually the confirmation of our hypothesis. Next one. Then we asked, well, since these animals don't have LIN in the entire body, is that because the leukemic cells don't have LIN, or is it because the microenvironment, so the host, doesn't have LIN? And that gave a couple of surprising results, and that's why I'm showing this to you. So basically what we did then, we transplanted the leukemia on normal mice and checked whether that could grow into leukemic animals, and vice versa. So basically normal leukemic cells into LIN defective mice. And the experiment is shown here. And what you can see, if you now grow these leukemia, whether they are with or without the Src kinase, they're just growing identically. Actually, we did a lot more experiments than this, but this is just one to highlight. And if you can see the growth curves over time, so when is the disease, the leukemia, growing in weeks, you don't see any difference. It's not a significant difference. So in other words, in the leukemic cells, You can have no LIN and still have leukemia. It doesn't make any difference. And then we did the opposite experiment, next one, which is to then take normal leukemic cells and have them growing on a LIN defective background, so where the hematopoiesis eventually of these mice doesn't work anymore because they don't have LIN. And that's a surprising result to be shown here. So basically, again, you have to check for the wild type. Wild type means normal, and the pink or magenta animals don't have LIN. So they have a hematopoietic system that doesn't contain this molecule, while the leukemia cells are normal. And the surprising result is that in the pink setting, in younger and older animals, especially if they're old, because at this point they have a damaged hematopoietic system, the leukemia doesn't grow at all anymore. And that means targeting these kinases is eventually more important in the microenvironment than in the leukemic cells. And actually, I can tell you we did a similar experiment, but it's not as far advanced, so we are not ready to publish with BTK and get the exactly same pattern. In other words, we may not really target the kinases in the tumor cells, but rather target kinases in the microenvironment. And I can tell you, if you check lymphoid cell lines, which we've done extensively actually for BTK inhibitors like ibrutinib, we didn't find any heavy growth inhibition in cell lines for ibrutinib because it doesn't really work. The evidence comes from clinical data, and the development of ibrutinib has been done because they saw efficacy in lymphoma dogs, and they were so impressed that they continued to develop the drug. So somehow, the mechanism of action of these drugs is not totally understood. We are always telling you they are BCR signaling inhibitors, but I will shed some doubt. Don't care somehow, because as long as they are so beautifully working, it's okay. But we may explore the interactions with the microenvironment a lot more to understand how they're acting and to get even better drugs in the future. That's the bottom line of this story. If I can have the next one. So the modulation of the CLL microenvironment, a leukemia that is addicted to the host. So the modulation of the niche is key to achieve therapeutic efficacy, both for chemoimmunotherapy and also for the novel inhibitors. That's a novel concept, and I think a part of the treatment that we have not fully understood and can even improve more in the future.